Good morning, everybody, and I thank the APVIC committee for inviting me and delivering a talk on this topic, natural history of carotid artery stenosis and stroke. Now, why is natural history important to us? It is important because it helps us to understand why we need to intervene, when we need to intervene, and what to expect if we don't intervene. I will start with giving some facts and figures. We have very limited Indian data, so I'm quoting the US data. Stroke is the third leading cause of death after cardiovascular causes and cancer. If we look at prevalence, it is present in 2.6% population and it is equally divided into both males and females. The prevalence of stroke increases with age. In the younger age group, less than 45, it is present only in 0.8% population. And in more than 65 years age group, it is present 8.1% of population. If we look at racial distribution, probably Asians are less affected by stroke, 1.6% in general population, and the Native Americans are the maximally affected. There are two types of stroke. One is ischemic, which is 87%, and the other is hemorrhagic, which is only 13%. And if we look at etiology of ischemic stroke, around 15% is because of atherosclerosis. This is US data. Maybe Indian data is slightly different. Some studies even quoted it's around 1/3 the atherosclerosis is the cause. Around 20% is the lacuna, 20% are cause of cardioembolic, and about 40%, 45% is cryptogenic or the reasons which are not clear. If we look at impact of the stroke, it causes markedly shorter life expectancy, almost 5 years to 8 years, and it decreases as the person ages. And if we look at the disabilities in patients who survive at stroke at 6 months, 50% patients do have some hemiparesis. 30% patients are unable to walk without some assistance. 26% patients are dependent in performing daily activities. 90% suffer from aphasia. 35% have depressive symptoms. And 26% patients, they require institutionalized care in a nursing home. So it's, as you can understand, it's a huge healthcare problem and a huge expenditure. Now we are specifically going for carotid artery atherosclerosis. The most common site is at the area of carotid bifurcation, the distal CCA and the proximal part of internal carotid artery. And patient at presentation, 37% patients are asymptomatic. To 10% patients, they have hemispheric stroke. 9% patients, they present with transient monocular blindness. And 24% patients have minor CVA or TIAs. And the risk factors, coronary artery disease and peripheral artery disease, almost 1/3 of patients in each category, they have associated carotid artery disease. Other major risk factors is hypertension, smoking, diabetes mellitus. Hypercholesterolemia is a doubtful risk factor specifically for carotid artery atherosclerosis, but increased LDL levels is a more important risk factor. Other risk factors are increased alcohol intake, gender, and race has been already described before. If we look at the reasons for stroke, probably embolization is the most common reason. And it happens because in the carotid bifurcation region, there is a plaque. In case it has a larger lipid core and the top fibrous cap gets thinned out, it can lead to ulceration, intraplaque hemorrhages, and subsequent embolizations. This is the most common etiology. Hyperperfusion is also there, is a second reason. It is less common and it's present only when there is a severe multivessel disease in both carotid and vertebral basilar systems. So the strongest predictors of future strokes in patients with carotid artery atherosclerosis is previous ipsilateral hemispheric symptoms. Symptomatic patients is the most important predictive factor, and second one is the degree of stenosis. Other predictors of future events are unstable plaques in the form of ulcerations, intraplaque hemorrhages, or intraluminal thrombus, as documented on investigations. Other is hemodynamic impairment. And the third important thing is the biochemical markers, which is the future and which is going to be studied and talked about in the future speaker's topic. Now, if you look at what is the risk of recurrent stroke, the maximum chances of stroke is within the first month, for 1 month after the initial stroke, and is almost 7% within 2 days and 10% within 7 days of the initial event. So it is thought that the maximum benefit of intervention is within the first 2 weeks of the onset of symptoms. Now, we have divided the natural history into two broad categories. One is for the symptomatic and one is for the asymptomatic patients. I will talk about the asymptomatic category first. This is about the true natural history. In a study published by Chambers in 1986, he screened about 500 patients with asymptomatic carotid broods, and the Doppler study was used for grading of carotid disease. And the outcomes was a TIO stroke occurrence at 1 year. He noted that almost in 0 to 29% category, 2.1% patient had neurological events. About 5.7% patients had event in 30 to 74% category. And in 75 to 100%, almost 20% patients had stroke. And you also see as the percentage of stenosis increases, the severity of stroke also increases. And also you can see the cardiac events also increase. In another study by Ollengren, 296 patients were studied and also showed the same thing. In less than 75% stenosis, stroke rate was 12.6%, and more than 75, 60% over the period of 5 years. He also studied the relationship of neurological events with carotid plaque characteristics, and which showed that if the plaque was soft and equiescent and had stenosis more than 75%, almost all patients had some kind of neurological intervention. So the plaque morphology is also important. If we look at the altered natural history, I mean to say in the newer studies, there is no natural history, but we can only show the outcome in the group which is best medical management group. First of all is a Veteran Affairs Cooperative Trial, 1983, which showed that in about 800 patients in further follow-up, 20.6% patients had episodic stroke and 9.4% patients had a severe stroke. In ACS trial, which studied 1,062 patients with 60 to 99% stenosis, 5-year stroke rate was 11%, and any TIA stroke for death rate was 9.2%. In the ACS trial, which is the largest trial in the asymptomatic category, it showed that 5-year stroke rate was 11.8%, and the disabling stroke rate was 5.3%. If we compare just a slight idea with the surgical groups, there were almost 5% absolute risk reduction if we do some intervention, and 50% relative risk reduction. But the combined event rates were quite high in studies, although ACAS just best benchmark with 1.5%. So to conclude in the category, it is relatively benign natural history of disease. The overall stroke rate in this medically managed group is only 2% per year. So the benefit of intervention is relatively small and is dependent upon the patient's selection. The patient should have a life expectancy of at least 5 years. It's important to note that there was no difference in stroke risk between patients in 60 to 99% stenosis and 80 to 99% stenosis categories. The plaque morphology is very important in these asymptomatic patients and is a relevant indicator for future events than the degree of stenosis. Now I'll come to the symptomatic group. There's no randomized control in the modern world which provide the true natural history, as it will be unethical. But the older studies show that almost 22% SDR over 2 years. In the ECS2 trial, in 3 years of follow-up, it's seen that, as you can see, the maximum risk of stroke is within the first year of the initial event, and it gradually dies down. In the NACID trial, we can also see that the stroke risk is dependent on both the multiple risk factors and the severity of stenosis, almost 25% stroke rate over a period of 2 years of follow-up. Now we divide according to the percent stenosis. In NACID trial, in 70 to 99% stenosis group, the stroke rate over 2 years was 26%. In ECS2 trial, In 80 to 99% stenosis group, the stroke rate was 20.6% over 3 years. In 50 to 69% stenosis in the NAFTA group, the stroke rate was 22.2%. And similarly, in 30 to 50% category, the stroke rate was 18.7% over 5 years. If we just compare between medical and surgical groups, there was a huge advantage of performing interventions in the more than 70% stenosis group and a relatively lesser advantage in 50 to 69%, but it was still significant. So I'd like to conclude with that. Unlike asymptomatic patients, symptomatic patients could be considered for intervention even if they have severe comorbid conditions and have a shorter life expectancy of 2 years. It is because the risk of stroke occurring without intervention appears to outweigh the increased operative risk, as most patients fear the disability associated with stroke more than they fear death. So, a much more aggressive approach is necessary for the symptomatic patients with respect to the timing of intervention to achieve maximum benefit, probably within first 48 hours if it is possible. Thank you.
Thank you. So you pointed out the fact that we don't know exactly what to do with asymptomatic patients. But if you, for example, asymptomatic patient, 90% stenosis, without any symptom, any brain infarct, silent brain infarct, this patient, you have to refer this patient to cardiac surgery. What do you do?
Well, I've focused most of the talk on the natural history. I've not classified what the intervention is required or not.
What do you advise?
But yes, in case there is a global and the global infarct which is already developed, there's an advantage which can be because that area of brain is already dead. Only intervention is required when the brain is at risk, when there is a stroke or a crescent of a stroke. The intervention is required. But once the stroke is established, that the brain is has global infarct, there's stroke.
Good morning. I enjoyed your presentation. The issue that we are faced with today, most of the data was acquired at a time when patients were not being aggressively with statins for their lipid abnormalities, nor were many of them even on adequate antiplatelet therapy. And consequently, many people feel today that the asymptomatic patient would well, regardless of the degree of stenosis, with medical management, as long as you have good compliance in terms of taking the drugs which modify their risk factors.
Yeah.
So I don't. This is an area of controversy, but because it affects people's incomes. If you're a surgeon or an interventionalist and you're treating, most of the people you're treating are asymptomatic, and you go to medical management, you've certainly lost a significant part of your personal revenue. But I still think, for the standpoint of the patient, until someone does a randomized trial, a good randomized trial that compares intervention versus current day aggressive medical management, I think the better course is to err on the side of conservatism in the asymptomatic patient.
Yeah, absolutely.
Thank you.
Thank you.
It's also very important that you have to define your asymptomatic group very accurately, because there could be a patient who's got a tight stenosis. He has not shown clinical symptoms, but if you do a scan, CT or an MRI, and you find infarcts over there which have been silent, this patient would rather be categorized as a symptomatic patient whose the embolization has gone to an area which is neurologically silent. What do you say on that?
Yeah.
And how would you, what duration do you call the patient being symptomatic? 180 days or within 180 days?
Yeah, 180 days.
Right.
6 months is
important.
the criteria. Thank you.